Hi everyone, and welcome back to Pediatric GI Essentials. Today, I want to walk you through a topic that, unfortunately, we encounter more often than we'd like in pediatric practice: esophageal burns following corrosive ingestion. These cases can be unsettling. A previously healthy child suddenly presents after ingesting a household chemical, sometimes accidentally, sometimes out of curiosity. In the acute setting, our response needs to be systematic because the decisions we make early on can affect the child's long-term esophageal function. So let's talk about how we grade the injury and, more importantly, how we tailor our management based on that grading. Let's start with the grading system itself. It's modeled after what we know from skin burns, and we use the endoscopic appearance of the esophagus as our guide. Grade 1 injury is the mildest. We see erythema or edema of the mucosa, nothing deeper. These injuries usually heal without any long-term issues. Grade 2 is where things get more complicated. We see erosions, ulcers, and sometimes mucosal blebs. But we further split this grade into 2A, which involves non-circumferential superficial ulcers, and 2B, which shows circumferential involvement, a key red flag, because this greatly increases the risk of a stricture formation, sometimes up to 70%. Then we get to grade 3, which means there's actual tissue necrosis or deep ulceration. If the necrosis is limited, we call it grade 3A. But if it's extensive or circumferential, we classify it as grade 3B. And that's when things become truly dangerous. Perforation is a real possibility. Now, once we've graded the injury, the management falls into place. Let's start with the mild cases, grade 1 and grade 2A. These kids typically do well. They don't need steroids or antibiotics. In fact, they can usually resume feeding early. We do recommend starting a proton pump inhibitor to support mucosal healing, but otherwise, the approach is straightforward. But once we hit grade 2B, things change. Because of the high stricture risk, we start corticosteroids, typically methylprednisolone, at 1 gram per 1.73 square meters per day for 3 days. We also consider antibiotics, especially when there's mucosal sloughing or ulceration, to prevent secondary infections. Feeding is delayed, usually up to 72 hours, to allow some healing time. When we get to grade 3, particularly grade 3B, we tread very carefully. Steroids, not effective. Feeding, delay is necessary. NG tube, that's controversial. While it can help keep the esophagus open and provide nutrition, it can also cause perforation, or worse, lead to long fibrotic strictures. So for grade 3B, our role is really to monitor closely, provide supportive care, and ensure early surgical consultation. These are the children at highest risk for complications like perforation, and missing that window for intervention can be catastrophic. And what about the long term? Any child with grade 2B or grade 3 injury needs ongoing follow-up. Even after discharge, they're at risk for delayed strictures, sometimes presenting weeks later with progressive dysphagia. In those cases, serial esophageal dilations or even surgical interventions may be necessary. On the other hand, if the child had no burn or just grade 1 or 2A, your prognosis is excellent. These kids usually recover fully without sequelae. So, to summarize, use endoscopic grading to guide decision-making. Start PPI from grade 2 upward. Use steroids and antibiotics only in grade 2B. Avoid NG tubes in severe burns unless absolutely necessary. Always involve surgery early if you suspect grade 3B. These are difficult cases, but a structured approach helps. Think clearly, act early, and always be mindful of the long-term implications. Thanks for listening to Pediatric GI Essentials. Until next time, stay sharp and take good care of your patients and their little esophaguses.